Hi everyone, and welcome to your first screencast with me for this course. I'm doing a screencast quite readily because this content would take up a lot of time, and frankly I think would be quite boring to kind of go through in class. This is going to support everything that we're taking, so I will be formally lecturing on the heart and blood vessels themselves. But this screencast has to do with specific arteries and specific veins that you are required to know for examination and then, frankly, further on in the program. So this whole screencast is on these specific blood vessels. So we're going to start with arteries first, and I'm going to go to the first one here. Well, off the bat, if we look here at the slide, then we start to recognize just how abundant vessels are in the human body. We can see here on the left, we see the torso, abdomen, upper legs, and proximal arms. We get a sense of just the significance of the vasculature in the area, and the heart, of course, sitting here in the center part. This is the hand. We have the radial and ulnar nerves here, or ulnar arteries here, and we can see, a fair amount of capillary beds in the fingertips and so forth. Then, of course, we have the massive amount of blood that goes to the head and face and supplies the brain and the muscles and so forth of the face, with our large carotid arteries here and so on. So we're going to start basically, as far as arteries go, sort of the largest one that's of importance, and then some of the arteries I'm going to be getting into sort of reflect on the pulses that you're required to know for your palpations and so forth. So we're going to start proximally. You did see in my video that I'm about to put out in regards to the great vessels of the heart. I will have also discussed this vessel to some degree when I'm discussing the anatomy of the heart as well. And that is the first artery that exits the first part of the heart. So the aorta is intimately attached to the heart, and then it distributes throughout the rest of the body from there. So because of where it lies and the amount of blood it needs to carry to go everywhere else, it is considered to be the largest artery in the body. And if you want to get a sense of how it is in diameter, it's about the size or the diameter of your normal garden hose. If you sort of get a sense of that, 1.25 to 3/4 of an inch depending, but you're fairly large in diameter. Now, when you look at it, and I do sort of show it a bit again in the videos, it is very thick. It is extremely thick simply because of the kind of pressures that it does. And if you remember, or you will see on my vessel lectures, especially in relationship to arteries, this is considered a muscular artery, and it has the ability to expand and contract to some degree in relationship to the rising pressures and the falling pressures at each heartbeat. Basically, it's about that same thickness all the way until it gets down to approximately where your belly button is. So the aorta starts at the superior aspect of the heart at the base, where the blood exits the left ventricle and comes up over the top and down to the point where your belly button is, where it bifurcates into the two iliac arteries. When we look at its beginning, then, it starts basically at what's called the aortic semilunar valve. This semilunar valve is right at the base of the beginning of the aorta, and it is a one-way valve which allows blood out of the left ventricle. And then during diastole, when the heart is relaxed, the pressure that exists in the blood wants to push back down into the left ventricle, and that is prevented from this valve, or these leaves of these semilunar valves. They flip out and they prevent blood from backtracking or backflowing into the left ventricle. Of course, if you can imagine, if there's any kind of disease that affects these valves, you'll get some leakage. Just above the semilunar cusps is an area called the aortic sinus. And there's a slight enlargement at this area. And within here, we find something called baroreceptors. Now, baroreceptors, if we do the terminology, baro represents pressure. That's why we have a barometer when we're measuring pressure outside for what's happening with weather. But in the human body, it's it's receiving information in regards to the blood pressure of the blood in the state that it's in as it leaves the heart. And of course, we want that 120/80 sort of running. And that's what this baroreceptor kind of helps regulate. So it's always sending back information to the brain to give a sense of where the blood pressure's at. And then any changes that have to occur to affect blood pressure will happen because of these baroreceptors that we find here. When we go and look at the aorta and its various names, it has to do where it is or where it lies in relationship to the trunk and the certain shape or location of it. So, of course, the aorta arises from the base of the heart, travels superiorly, and because it's traveling superiorly, it is known as the ascending aorta. In other words, it's traveling up. And then as it ascends upwards, it starts to run posteriorly and to the right of the pulmonary trunk. It persists for only 5 centimeters before curving to the left to become the aortic arch. So it travels a little bit right to allow the pulmonary trunk or the pulmonary arteries to move up out of the right ventricle and then goes immediately left into this arch that travels up and back to the left. There are only 2 branches off the ascending aorta, and that is the left and right coronary arteries. So right at the base of the aorta and the ending of the aortic semilunar valve, there are on either side a right and a left vessel that exits the base of the aorta, and these are the right and left coronary arteries. And as I talked about in coronary circulation, this is where blood then backtracks down these coronary arteries to supply the needs of the myocardium of the heart, remembering that those vessels run superficially along the heart itself. So we see here is represented the aortic semilunar valves, and then we see it goes slightly to the right to make room for the pulmonary arteries, and then goes to the left, creating, sorry, I lost my cursor here, creating the aortic arch as it travels up, back, and to the left-hand side of the spine. The spine would be running approximately down this side here. The aortic arch is deep to the sternum and ends at the sternal angle. I don't know if you guys have taken the sternal angle yet in your anatomy class. I believe you likely have at this point, but imagine at that point is that this aortic arch ends. Off of the aortic arch are 3 major branches. The first, or the most proximal, is the brachiocephalic artery, and it is called brachiocephalic because it's singular and it will eventually split to supply the upper arm and the head, hence the name the brachiocephalic artery. It passes superiorly under the right clavicle and branches into the right common carotid artery to feed the right head, and the right subclavian artery to feed the right arm. And this travels superior to the apex of the lungs, which sits right behind and slightly above the clavicle itself. The next branch, the middle branch, as we travel distally from the heart, is called the left common carotid, which supplies the left head, and then the third branch off the arch is the left subclavian artery that supplies the left arm. So the right side of the body, head and arm, comes off of or out of the brachiocephalic artery, whereas the artery that supplies the left part of the head and the left arm comes right off of the aortic arch itself. So we can then say that the aortic arch and its branches supply the head, neck, upper limbs, and part of the thoracic wall. There are small arteries that do supply the thoracic wall, but they are not going to be part of my discussion here. So we can see here how we see the slight right, which allows, right here we see the pulmonary artery that has left the right ventricle to go out to the heart to get blood. So the ascending aorta has to travel slightly right, and then it starts to arch and travel left. The first branch here being the brachiocephalic, which then splits into the right common carotid, which supplies the right head, and the right subclavian, which goes on to supply the upper right, or the full right arm. The next branch behind that, or distal from it, is the left common carotid, which supplies the left side of the head. And then the last branch here is the left subclavian, which travels over, you'll see the pleura here, so it's traveling over the top of the lung behind the clavicle to supply the left arm. This is with all that stuff removed. So we see here the heart would lie here. Here is the pulmonary artery that will send deoxygenated blood to the lungs for gas exchange. And then we have the semilunar valve, which would be here. The right and left coronary arteries would come right out here at the bottom. We then have the ascending aorta, which becomes the aortic arch. Here we have the brachiocephalic, the left common carotid, and then the left subclavian. The next part, as we travel distally from the heart, is the thoracic or the descending aorta, and it runs along the right side of the anterior vertebral bodies of the spine from T5 to T12. And I'm sorry, I've got that wrong. That should say the left side of the anterior vertebral bodies of the spine from T5 to T12. It can leave a slight indentation on the vertebral body simply because of that pressure part. Again, I will repeat, this is on the left side of the vertebral bodies. There are branches that do come off here. There's the pericardiac, the bronchial, the esophageal, and the posterior mediastinal. These are small branches that come off that supply certain structures around the mediastinum, such as part of the esophagus, part of the bronchial tubes, and some parts of the tissues around the heart. Again, I won't be examining on these, but just understand that there are some branches that come off, which we see here. So small branches coming off. So we have the esophageal branch of the right bronchial artery. Okay, so this long tube here is the esophagus, which is eventually going to get to the stomach, and so forth. So we see it lying here is the heart. Here's the ascending, the arch, and then the descending or the thoracic aorta that we have here. We do have also minor branches that come off the descending, which feed the intercostal muscles between the ribs as we work our way down. The last part and the most distal part is the abdominal aorta, and this supplies a lot of the major organs of the abdominal viscera. And because of that, we tend to find fairly large branches, and they can be paired or unpaired depending on where it is that they're going. We think of the abdominal aorta's boundary starting at the opening in the diaphragm. So as the aorta travels through the hiatus of the diaphragm, above the diaphragm is considered the descending or thoracic aorta. Below the diaphragm is considered to be the abdominal aorta. And it remains still on the left side of the vertebral bodies. And then it terminates where the aorta bifurcates or divides to become the two iliac arteries, and this is approximately at the umbilicus. And as I said, some of the branches off of this abdominal aorta are paired and some are unpaired. Some branch off anteriorly, but most branch off laterally, either left or right. So we see here working our way down, we have these three, the coeliac, the superior mesenteric, and the inferior mesenteric. These tend to supply a lot of the organs within the viscera. We have the suprarenal here and the renal. The renal supply the two kidneys on either side. We have the gonadal here, which is going to supply the gonads, which are some of the internal organs, the uterus, the ovaries, the prostate, and so forth. And again, I'm not going to get into a whole lot of those, just understand that there are these branches that are here. We also have the common iliacs, which travel out to supply both legs. And then, again, this bifurcation occurs approximately at the umbilicus. The next major artery we need to talk about is actually a group of arteries. If you remember in the lectures, I talked about an anastomosis, which is a branching of arteries coming together and sharing blood to some degree. So the one we're talking about is called the circle of Willis that we see here on the left-hand side. And it's made up of a number of arteries coming together. If we think about the anatomy of when we look at the aorta, we have some supply here. We've got the we've got the arteries coming in behind here, just so you have a bit of a better picture, and we've got the vertebral arteries that are coming up. Now, I don't know if you took the vertebral arteries much in Jill's class, but if you remember correctly, in the cervical spine, you have the foramen transversarium, which has two arteries coming up through those foramen transversarium to eventually enter into the base of the brain. And that's where we see here at the bottom are the beginnings of this anastomosis. So we'll have the left and the right vertebral arteries here, and they'll come in and around the pons that we see here, and comes together and builds this beautiful circle that comes all the way around that helps to supply the head that we find here. When we go back to all the way back here to the branch here of the arch of the aorta, we have something here called the common carotid. As the common carotid leaves the large vessels off of the arch, whether it be the brachiocephalic here for the right, or the left common here for off the arch itself, it splits into an internal and external carotid artery. So we see here in the diagram, here are our internals here. So they will, that carotid develops into an external one that travels outwardly, and then an internal one that comes in and helps supply this circle of Willis. Ultimately, before I talk about it formally, I just want to understand that this is all oxygenated blood. And if we lay this on top here, we see it here on the workings of the brain itself. And this is the inferior part of the brain here. We're looking at the bottom of the brain. Now you can understand how the blood that comes into this area, whether it be from the internal carotids or whether it be from the vertebral arteries, serves to meet the needs of the entire brain's blood supply and meets its needs. So, the circle of Willis is in fact an anastomosis that is found at the base of the brain. It is made up of 5 pairs of arteries to ensure the posterior part and the anterior part of the brain's blood supply are united. Thus, this results in a vast amount of the brain being supplied. And basically what happens is this anastomosis arises from the pair of vertebral arteries and the pair of internal carotids. So we have the 2 internal carotids here that are starting to supply, and we have the 2 vertebral arteries here. Then all these other paired networks, along with these communicating arteries, form this entire network of arterial blood that serves the brain. And because they are all connected, it is an anastomosis. The vertebral arteries unite at the caudal, the lower part border of the pons, to form what is called the basilar artery, which is this long line here. So again, here on the real brain, we see the 2 vertebrals here, and then we have the basilar artery running here, which gives off a number of paired branches to divide into the 2 posterior cerebral arteries, which are these 2 here. So we have the 2 vertebral arteries, and then we have the basilar artery that's running here along the pons, which then divides into the 2 posterior cerebral arteries that we see here. And there are other branches here, but I'm not too concerned with getting into them. Just you understanding that we have the 2 vertebrals, the basilar, and the 2 posterior cerebrals. The vertebral basilar arterial system supplies the posterior circulation of the brain. So this is basically all of this to here is found here and is supplying this posterior aspect of the brain. There is a branch off of each posterior cerebral artery that travels to the internal carotid, and it is called the posterior communicating artery, of which there are two, which we see here, 1 and 2. And they find communication with the internal carotids, both right and left. Oops, sorry. The internal carotids continue to form the two middle cerebral arteries, okay, here and here. So they're the internal carotids until they meet up with the posterior communicating, and then they continue outward to supply the brain. They are called the middle cerebral arteries here and here. The internal carotids continue to form the two middle cerebral arteries, and then there is a branch which connects the two anterior cerebral arteries, which is called the anterior communicating artery, which we see here. So all in all, we have two pairs of arteries that supply this entire anastomosis. We have the two internal carotid arteries here. We have the two vertebral arteries here and here. The two vertebral arteries feed the basilar artery and the inferior cerebral artery and the posterior cerebral artery, and the two posterior cerebral arteries here. So we've got internal carotids, basilar, and the two posterior cerebral arteries. There is a branch off of the two posterior cerebral arteries called the posterior communicating arteries that communicate with the internal carotids here and here. On the other side of that point where the posterior communicating artery communicates with the carotid, the internal carotid, it then is called the middle cerebral artery. And we can see here it's basically the same artery, but because it's on the other side of the posterior communicating artery, it is now called the middle cerebral. And another branch on the other side, going towards the anterior part of the brain, are the two anterior communicating arteries that we see here and here. The anterior cerebral arteries supply most of the medial and superior surfaces of the brain and the frontal pole. The middle cerebral arteries supply the lateral surface of the brain and the temporal pole. And the posterior cerebral arteries supply the inferior surface of the brain and the occipital pole. So we see them all here. This is laid out on top of the brain. Our two vertebrals, our two internal carotids, our basilar, our posterior cerebral here, our posterior communicating, our anterior communicating, and our middle cerebral arteries here and here. And then coming off of the two anterior communicatings are the two anterior cerebral arteries here. This is an actual brain that's had a red wax placed into the vasculature. This is our two vertebral arteries here and here. This is our basilar artery. This is our posterior cerebral here. This is the posterior communicating that we see here. The anterior communicating would be in behind here. These are the two internal carotids. This is the middle cerebral artery that we see here. And then here are the two anterior cerebral arteries here. Therefore, we can say that the cerebral arterial circle, known as the circle of Willis, is an important anastomosis at the base of the brain between the four arteries that supply the brain. The two posterior cerebral arteries, the two posterior communicating arteries, the two internal carotid arteries, the two anterior cerebral arteries, and the two anterior communicating arteries. And of course, there are a vast number of small branches that come off here. What's very interesting about this and why this is so important to the brain, any one of these arteries could be completely clogged and unable to function, and the brain will still get a good supply. A bit of something in my personal life was one of my brother-in-laws, his left or right, I believe it was his right internal carotid completely occluded with a clot. he did have a very minor stroke that took place here, back here in the occipital part of the brain. Other than that, nothing else happened. And they decided not to do surgery to fix this occlusion simply because they discovered that the brain's vasculature, when they looked under at the brain under an MRI, was getting all the blood that it needed, even though one of the internal carotids was completely plugged. So this is why this anastomosis is so vitally important to the brain, because it allows the possibility of the brain getting what it's need via other avenues if there happens to be anything that happens to any of the arteries along the way. The next artery is an artery you can use as a pulse. It is called the facial artery. It arises between the hyoid bone and the base of the mandible. It winds its way in front of the external carotid from which it originates. It then moves forward and upwards towards the submandibular gland, passing onto the face where its pulse can be felt as it crosses the mandible, just antero-inferior to the parotid gland. It courses up over the face, emerging by the edge of the lips and ascending between the nostril and the cheek. And because of its superficial course, the pulse of the facial artery is palpable at the antero-inferior angle of the masseter muscle against the bony surface of the mandible, which we see right here. Okay, we also see it here in the drawing. Part of the mandible has been removed here so that we can see the vas network. So here is our external carotid here. Here's the internal that's going to go off to the circle of Willis that we just talked about. Here's the external carotid here, and you can see that the facial artery passes off of it, and then around the parotid gland and up over the bottom part of the mandible itself, where in this area we can palpate it. The next is a subclavian artery, and this subclavian artery is vitally important because it can play a role in a pathology known as thoracic outlet syndrome, and it is something that we test for when you go into assessments class, but it is also something that we can help treat as massage therapists in some cases. So it's very important to know where this is in relationship to when you come across this condition. So the subclavian arteries are a pair of large arteries in the thorax that supply blood to the thorax itself and the head via the vertebral arteries, neck, shoulder, and arms. The right subclavian is located below the clavicle. It branches off the brachiocephalic trunk that we talked about. The left subclavian artery branches off the arch of the aorta and ends at the first rib's lateral edge, and at this point it turns into what's called the axillary artery. And what's important to understand about this is that it passes between the anterior and middle scalenes. So when we get down to the attachments of the first rib and the clavicle, when we look at the anterior middle scalenes, they separate ever so slightly, which creates a bit of a foramen that the blood vessel passes through, which we can see right here in the diagram. So here is the brachiocephalic artery that we see here as it's come off the aorta. It is then going to branch off into the right common carotid, and then it will continue on as the subclavian past that area. So the brachiocephalic here, and we have the common carotid here, and then eventually will become the right subclavian as it moves onwards. This is a lovely picture because it also shows you the vertebral arteries I was just speaking of in the circle of Willis as they travel through the foramen transversarium to eventually go into the anastomosis of the circle of Willis, and we can see it nicely here how they come together. This would eventually be the basilar artery. But what we're talking about here now is a subclavian, which we see here in the drawing. And then, of course, we have the subclavian continuing here as the branch off of the aorta as we get farther away. As the subclavian moves more into the axillary region, it is called the axillary artery, which eventually will become the brachial artery. But for our purposes, and what I want you to take away today is this space created by the middle and anterior scalenes allows this artery to pass through. Now, imagine, if you will, that something causes these muscles to become extremely tight and starts to push on this artery. it's going to start to have a distal effect in the arm of the areas that this blood supplies, such as tingling and weakness. We do some tests for this, which you'll learn, but all I want you to take away for now is just this relationship here between the muscles and understanding that this passes over the rib and travels onwards to do the arm. So it went from the subclavian to the axillary, and as it continues out of the axilla, it then becomes the brachial artery. So we say it is a continuation of the axillary artery, which was a continuation of the subclavian. It begins at the distal border of a muscle called teres major and terminates by bifurcating or splitting into two into the ulna and radial arteries, just distal to the bend of the elbow in that antecubital area. So here we see it. Here is the axillary artery here as it travels through the axilla. So just some landmarking here. Here is pectoralis major. Here is biceps brachii that we see here and here. And we are traveling medial to biceps brachii, slightly underneath the short head moving in here. And you should all know this artery simply because this is the artery that you palpate when you're doing blood pressure. And if you're doing it correctly, this is where you should be palpating that artery within this area here. I far too often see students palpating it at this point, which is very difficult to get a palpation here. Your blood pressure cuff should actually be lying just at the distal end here of the brachial muscle, of the biceps brachii, and with that arrow lying right on top of this artery, hence the reason why you palpate it. So in some ways, if I were to show you in class, you would slightly move the head of the biceps out of the way to access this artery to get a feel for it. We can also see it here as it's traveling without any musculature into this area. Just as a sidebar, you'll note that there are some branches off of this brachial artery that creates an anastomosis around the elbow. So you see where the bifurcation is here into the ulnar and the radial arteries here, which takes us to the ulnar radial artery. And let's do the radial first. So it is the smaller branch of the brachial bifurcation, and it is a direct continuation down to the wrist. So this is the reason why we use the radial artery pulse, is because there's no bend in the artery as it moves distal to the wrist. It is a straight line down all the way to the wrist. The radial artery enters the wrist on the lateral side, where it bifurcates into a superficial and deep branch, which then anastomoses with the ulnar artery. The ulnar artery is the larger branch of the brachial bifurcation. It passes along the medial border of the forearm into the wrist, where it bifurcates into a superficial and deep branch, where it of course, anastomoses attaches to the deep and superficial branches of the radial artery. And what happens is the anastomosis that's created by these radial and ulnar arteries is also known as the palmar arches of the hand, which we see here. So here is the brachial artery here. Here is the bifurcation right here, where you'll see it's a straighter line where the radial artery continues, comes to the radial side of the hand, or somewhere around just proximal to the styloid process. It bifurcates into the deep and the superficial palmar arteries. The ulnar is larger, but bends a little bit. It comes off the medial side, of the forearm, travels down through the musculature, and comes out again at the wrist, where it too bifurcates into a superficial here that attaches with the superficial palmar artery of the radius, and a deep, which also attaches to the deep of the radial artery, thus forming these palmar arches, or this beautiful anastomosis of the hand. The next is the femoral artery, which from time to time can be used as a pulse. It is a very large artery in the thigh, and it is the main arterial supply to the thigh and leg. It enters the thigh from behind the inguinal ligament as the continuation of the external iliac artery. Remember, the iliac artery is where the abdominal aorta bifurcates. And here it lies midway between the anterior superior iliac spine and the symphysis pubis. So we see it here in both drawings. Here's the inguinal ligament that we see here. This is the femoral artery running on the inside of the leg here, or of the thigh. We see it here as well. This is a lovely drawing of the inguinal ligament. Here is the pubic symphysis here, the anterior part of the pelvis. Here is the iliac spine here, the ASIS being here, and it runs just underneath it. An easy pulse you can try on yourself for sure. The last one is the dorsalis pedis, or the dorsal artery of the foot. This is a very unique artery in that it's used for if there's any kind of damage done to the proximal leg, they will check this artery to ensure there is good circulation to the foot. If there wasn't, of course, there would be concern of the patient losing the foot, so they're always trying to find it and to listen to it. I can tell you it can be palpated, but can be difficult. In the hospital setting, quite often what they use is an ultrasound to hear it, to find it before they palpate it to ensure it. So the dorsalis pedis artery is a blood vessel of the lower limb that carries oxygenated blood to the dorsal surface of the foot. It arises at the anterior aspect of the ankle joint and is a continuation of the anterior tibial artery. It passes from the ankle joint along the tibial side of the dorsum, remembering that the tibia is the medial bone of the lower leg, where the fibula is the lateral bone of the lower leg. So along the tibial side of the dorsum of the foot to the proximal part of the intermetatarsal space. So this would be the spaces between the small bones of the foot. There it divides into two branches, the first dorsal metatarsal artery and the deep plantar artery. So again, it's kind of forming a bit of anastomosis again. Along its course, it's accompanied by a deep vein, the dorsalis pedis vein, the extensor hallucis longus, and the extensor digitorum brevis muscles, and the longus tendons can also be located close by. So we see here is the dorsalis pedis artery here, traveling anterior to the ankle joint. We see it here in its relationship to the tibial artery, running down here, then becoming the dorsalis pedis right here. And we see it in relationship to the various tendons here. So here's the extensor hallucis longus, and here is the first dorsal metatarsal artery here coming off of it, and so forth. So we see sort of where it's lying, sort of on this tibial side, on the dorsal surface of the foot. This ends the artery. Move on to the veins, which there are not as many, but they unique to the limb as well. So just some things to remember that, when we were looking at arteries, remember that arteries are very large at the heart, and as they move distally, they get smaller. Whereas with veins, they start small, and as they get closer to the heart, they become larger. And remember that veins return blood to the heart, and arteries take blood away from the heart. So the two we need to think about are the ones directly dumping blood into the heart. So that the first is the inferior vena cava, which collects most of the venous blood from any of the organs and legs and any structures inferior to the diaphragm. It passes through the diaphragm to enter into the posterior heart at the right atrium. And one thing that's very interesting about the inferior vena cava, you will learn in my lectures that by the time blood gets back to the heart from the venous system, its pressure is almost that of zero. So it's very difficult for it to move into the heart. And one of the benefits of the vena cava passing through the diaphragm is that every time you breathe, the diaphragm contracts and it milks the inferior vena cava, pushing blood up towards and into the heart. So we see it sort of here in this diagram in behind where it's going to enter into the right atrium. We see it here as it's coming through as well, bringing venous blood back from a number of organs, the lower limbs, the kidneys, and so forth, back into the heart. The upper parts of the body bring blood to the heart via the superior vena cava. So this vessel receives blood from the tissues and organs of the head, neck, chest, shoulders, and upper limbs. And basically, again, it comes in at the posterior aspect of the right atrium, bringing blood back to the heart. So we see it here sort of following along the same lines as the aortic arch and subclavian arteries, and so forth. So it's bringing blood back from the head, neck, shoulders, some of the some of the organs superior to the diaphragm, and brings things into the right atrium from above. Returning back from the head as well and feeding into the superior vena cava are the internal and external jugular veins. The internal jugular vein starts at the jugular foramen, which descends parallel to the carotid and receives blood from the cerebral sinuses. So the internal jugular is getting a lot of the venous blood from metabolic requirements of the brain. The external jugular vein is a superficial vein of the head and neck, and the facial vein drains into the external jugular, and you can actually kind of see it when you look at someone's face. If they're very angry, sometimes it can very much stick out. There is an anastomosis between the internal and external jugular veins at the angle of the mandible, which provides dual venous drainage of the face, scalp, and cranium. Isn't it funny that the bifurcation of the internal and external carotids are right around the same area? The external descends towards the chest, just deep to the skin on the anterior surface of the sternocleidomastoid mastoid. So we see here's the SCM, and it's we see here the internal is running behind the SCM, whereas the external jugular is running anterior to the SCM, what you can see here. We don't have to be too concerned working on the SCM with this here. Arteries would be a little bit different, but veins we don't worry quite so much about. We see it here as well as it's coming. Here is here we see the jugular here, and with the internal and the external here. We're going to jump all the way down to the legs. Another couple of important veins that we have to speak about because you could be seeing this in practice. And these are the greater and small, or the great and small saphenous veins. The great ascends along the medial aspect of the leg and thigh and drains into the femoral vein near the hip joint. And the small saphenous arises from the dorsal venous arch and ascends along the posterior and lateral aspects of the calf. So here we see here's the great saphenous on the outside of the leg, and here's the small saphenous on the medial aspect with the deep vein running right up the middle. The reason I bring these up is because these veins are the ones that can suffer from something called varicose veins. And what we see with varicose veins is weakening of the walls of those veins in the area around where we find those valves that I talked about in class, or will be talking about in class. And these valves have weakened or become stretched. And what happens is you get significant pooling of blood in these areas. And the pooling results in the vessels becoming very much distended. So we say the valves may not work properly. Blood then pools in the veins because of low pressure, because it's in low pressure. And the vessels become grossly distended. Another form of varicose vein, as some of you may suffer, or you know people who do, are hemorrhoids. Hemorrhoids are nothing more than the same idea. They are a varicose vein in the veins around the anus area, and they become so distended with blood that they can actually stick out looking like small blueberries, like a sort of a bunch of blueberries coming off the edge of the anus, or just a large distended area beside the anus area, and they are nothing more than a varicose vein. So we can see here in the diagram the normal veins that we see here, which allows blood to continue. But when those valves start to break down, we get significant pooling, and we get extremely distended veins, which results in these significant convolutions. We see them here in the diagram, how much blood they can carry, and become quite enlarged and quite distended simply because of the blood that's pooling, because the valves aren't continuing the blood upwards, and the blood tends to pool in these areas. That ends the screencast on the specific veins and arteries. You will be expected to self-study these. That's why I'm making them into a screencast. I'll be explaining this in class this week. But thanks for listening, and have a great day.